what do we do to make that happen more quickly? What are the next steps? And just to be realistic, it's probably, I think, naive to think that under either of the people that are likely to win the presidential election this fall, it's, I think, naive to think that either of them are going to suddenly become supporters of Medicare for all and single payer. And so it's not likely that that legislation accomplishing our goal will happen um, under either of those people as president. Although we will keep trying, and I'll talk about that a bit. So instead, what we've been thinking for the next 2 to 4 years is what are the foundational things that we can be putting in place that will make it will accelerate the process of getting there when it's something that's closer within our grasp again. And that's what I want to talk about with you tonight is some of those things, and there's a lot of them, and there's a time schedule that I wanted to sketch out to you, some of which starts on Wednesday of this week. So it's really a handy point in time. And these are things that, at least from my perspective, all point towards getting us to Medicare for all. So of course, when the new bills for Medicare for all are updated and are resubmitted in 2025 in the new Congress, of course, that will for that time be our top priority, trying to get co-sponsors to the bill. But there's a whole bunch of other things we need to be doing and that we are able to do. So the most important thing is to sort of build our power, become more influential. And it turns out that there's a lot of the things we want to work on have pretty broad interest. So the biggest immediate threat to healthcare seems to be the privatization and profiteering that is ripping healthcare apart in every part of the healthcare system. And I'm not going to unpack that. You all know, nursing homes, hospice, dialysis, medical groups. It's all over the place. And so, if we wanted to try to have a campaign exposing and addressing this, there's too much. There's too many targets. So what we decided was to pick one specific target that's sort of a poster child for how healthcare system is under attack, how if left unfettered, we won't have a Medicare system to build a Medicare for all solution to. And so we picked one, and the one that we picked to focus on, as you probably know, is Medicare Advantage. We believe that Medicare Advantage is really damaging and dangerous. So we sketched out a several year, frankly, campaign. And this, as you may know, started a couple of years ago, and the first phase manifested late last year, fall of last year, when we released, I think of it as a groundbreaking report showing that the national dialogue about Medicare Advantage was understating how dangerous it is financially to the country. It was commonly talked about, oh yeah, Medicare Advantage is overpaid by about $20 billion from upcoding. That was the conversation if we would go to members of Congress about Medicare Advantage. They would agree it's $20 billion in upcoding. And we thought, well, upcoding is just one of the ways that these Medicare disadvantage corporations are getting these subsidies. And we hadn't seen anybody, we'd seen lots of organizations or think tanks and research groups that were identifying characteristics of overpayments in these ways, but we hadn't seen it rolled together. So we spent most of a year rolling all that together and revealed last year that the subsidies are not 20 billion, but perhaps as high as $140 billion, nearly an order of magnitude larger than what people were talking about. And it's from a multitude of factors. So, I mean, I think that report was the first of then a few that followed from others showing that, yeah, it's a big number. It's a bigger number than we thought. There are more factors. It's not just upcoding. And as a consequence, now when you hear people talk about it, they're typically now using a much larger number than 20 billion. They're often saying 83 billion or 88 billion or roughly 100 billion. So I think our first little salvo into this campaign accomplished our primary goal of exposing the scope of the problem and shifting the national dialogue. So, okay, that was good, productive, a good, useful contribution. But then, we're not economists for a national health program. We are physicians for a national health program with, as you know, many non-physicians in our organization and very important roles. But the first concern that most of us have is, frankly, it's not so much the economics, although as important as that is, it's the health outcomes. So that we believed Medicare Advantage was disrupting and harming. So we spent the next several months working on the second report that came out, I don't know, about a month ago or so, that exposes the wide range of harms within that are being perpetrated on us by Medicare Advantage, and that was our second report. So put together, and it turns out that tens of millions of Americans are being really hurt by Medicare Advantage, as are physicians all over the country, and frankly, even hospitals. So with this second report, we've now shown that that they're completely not living up to their promise, these Medicare Advantage corporations. They were set up to lower the cost of healthcare for the country by improving health outcomes. They're doing neither of their goals. We're being cheated. We're not getting the things that they were created to contribute, and instead they're doing the exact opposite. Okay, so we're decided to focus there, and that's what the first two reports were about, and we have a third one that we're just starting to conceptualize for later on. But now what do we do with this? Because these are pretty powerful new tools that we haven't had in the past, and so we're entering this very busy season for the campaign. And over the next 2 years, because we're now thinking on those kinds of timeframes, fortunately, there's at least 4 critical moments, one of which is coming right up, but there are at least 4 critical moments that the campaign that we are developing is focused on. The first is the open enrollment process for the year 2024, for this year, for the 2025 membership. So we want to use our new reports to change the dialogue around the country about in the ways I was just talking about. So that's the first moment that we're focused on, and that's what most of what I'll be talking about in a few minutes is focused on. But then, right as soon as that ends, the next thing that happens in Medicare Advantage land is once a year, the Centers for Medicare Services proposes what they want to make the new rates for Medicare Advantage. They typically propose a significant increase year over year of how much Medicare Advantage companies will be paid. And that's going to happen early spring, late winter in 2025. And we want to do a campaign to mitigate that, to reduce that, to have an impact on that. And there's reason to think that we have been and will be more so successful at that. So that's early spring, late winter 2025. And then right on the back of that, of course, we need to be ready for open enrollment 2025. So we're finding ways to connect these things in a campaign that builds on itself. And then through there, there will be the fourth event, which of course will be the refiling of the Medicare for All bills in Congress, for which we need to get even more co-sponsors, House and Senate. So the first part of this is, as I was saying, is preparing for open enrollment, which starts in October and then runs through December. So the first and most pressing thing for now through December, for the rest of the year, is to try to change the national narrative about Medicare Advantage for the open enrollment season. It seems to us that the national discussions about Medicare Advantage during the open enrollment seasons tend to be fawning, tend to be very very, oh, look, you can get more benefits, look at these lovely things, and don't mention the fact that the reason Medicare Advantage corporations are able to offer extra benefits when they do is because they're subsidized to a level that people in traditional Medicare don't have access to. So we need to expose that, the unfairness of that. We need to expose that people are frankly gambling with their lives when they make the decision to go into Medicare Advantage, if it is their own decision to make. So we want to change the dialogue, the national narrative, such that open enrollment 2024 has a different character to it. with the hope being that we won't reverse we won't Medicare Advantage isn't going to disappear because we've exposed these things, but we want to slow down the train. We want to show that there is actually the power here. So there's a number of pieces that we've been constructing with some terrific allies to make this happen, to change this dialogue. The first, as I sort of alluded to, is this week. The first is this week, Wednesday, and I'll put the link to this in the chat when I'm through blathering here. But this week, Wednesday, at 5 o'clock Pacific time, 8 o'clock DC time, at 5 o'clock this Wednesday, one of our terrific allies, Be a Hero. And I don't know if you know this group, Be a Hero, but they were founded by Adi Barkan, an incredible advocate who died recently. But he tremendous organization, very well aligned with all the things we want to do, in terms of single payer and Medicare for all. They're right there with us, from a different set of tools. And this Wednesday, Be a Hero. What a great name, Be a Hero. Be a Hero has organized a training program for people who want to get better at doing public outreach regarding Medicare disadvantage programs. So they're oriented towards people who are doing farmers markets and other community programs. And it should be terrific. I know some of you are already doing that kind of work, and I imagine there will be chances to chime in during the session with your own ear wisdom. But it's a pretty highbrow group. They do a great job at these things. So I suspect any of us who go to it can learn. So that's Be a Hero training this Wednesday, and I'll put the link to it in the chat when I get through. So that's the amazing timing of tonight, and then beyond that. PNHP has been organizing a bunch of things, some of which don't yet have dates. But the first one will be sort of our version of speaker training. And this speaker training will be more sort of in the traditional PNHP channels. It'll be building comfort on speaking to medical groups, to physician groups, and then some of the other groups that we often speak to, senior groups, retirees, and others. So we'll be organizing sort of a more robust training program on that, and a whole bunch of other actions over the summer. So I'll put up a second link to the PNHP stuff, and it'll give you like a checkbox of things you can express interest in. And then as those get a little bit more developed, you'll be able to sign up as you wish. You'll be told about those things that you've expressed interest in. And all of this, the Be a Hero program, all of the PNHP training and other things on that list are leading up to a day of action that's going to be hopefully going on around the country on Monday, September 30th. So right before open enrollment starts, Monday, September 30th, a day of action aimed at exposing the insurance companies' problems, using all the tools that we have developed, including, of course, the information that was exposed in our 2 reports, and other things. And so the idea is to have actions all around the country focused at insurance companies. And the one in New York will be on Monday, September 30th, and they're expecting a pretty large event. And we're hopeful that other events like that will be happening all over the country as well. It's a little bit of a...
We can do that. Yep.
Yeah. We'll do something.
Good. Yeah, it's a little bit of a challenge doing things on a Monday, so don't feel like you can only do it on a Monday. If you decide, locally that Saturday's better or Sunday's better, don't feel like it's got to be Monday. It's what they said. Don't feel like that, because actually, I think it's better to have the dates scattered a little bit, so that if you do something on the Saturday, the press about that, if it gets press, will be picked up in Florida. Florida does something on Sunday, and the press for that gets picked up in New York. I think it can build on itself. It doesn't have to be a single day, but a day or two around September 30th. That would be great. So yeah, when you sign up on the thing, you can get more information about that. So that's sort of the first wave, or I guess now that we're in our second report, this is now the third wave. That's the current wave that we're entering. Then right after that, the next organizing moment, as I was saying. This isn't as here yet, but the next organizing moment to have in your head the narrative of where we're going will be about the Medicare Advantage rate adjustments. So I don't know if you know this success story that you should be really proud of. 2 years ago. So every year, Medicare announces what they think is the right amount that Medicare Advantage corporations should be paid. Every year they come up with a draft of that, a proposal, and every year for more than a decade, the insurance industry yells at Medicare Advantage and uses all of their lobbying pressure to get Medicare to raise the rates significantly, sometimes dramatically above what the CMS actuaries actually thought was adequate and appropriate. So for years, there hasn't been much of an organized pushback on that. 2 cycles ago, about 3 people, maybe 4 people, advocates, went and talked to Congress and talked to CMS and tried to advocate to give Medicare the courage to hold to the rate that they thought was appropriate. And they had good conversations, but the rates still kind of jacked up crazy. But we paid attention to what they did and we learned from it. And so this past cycle, this early spring this year, PNHP was with our allied groups of a massive campaign, dramatically different. So we, with Be a Hero and Social Security Works and Public Citizen and Just Care and People's Action and other groups got together, and we had, I think, north of 40 meetings, 45 or 50, I should have the number, I'm sorry, meetings with members of Congress or their staff, and I don't know, thousands of op-eds and thousands of letters, many op-eds, and lots of other things. And so this year, for the first time in Medicare Advantage's history, this year, thanks to all of the pressure that our advocacy work did, CMS released the rates that they thought were appropriate according to their actuarial analysis. We descended on them saying, we're watching you, we're going to see what you do, hold to these rates. You decided that they were appropriate, do not bow to industry pressure. And indeed, industry leaned hard on them saying, oh, the sky is falling if you do this. And for the first time ever, Medicare had the starch in their collars to not increase the rates. The rates were held to the original actuarial proposal. Advocacy works. Advocacy works. And that was sort of just the first time we did a campaign like that. So, we're going to ramp that up to a larger intervention, larger actions, perhaps a bigger demand. We haven't got that organized yet, but more of that in early spring 2025. And then immediately following that, of course, will come the campaign getting ready for open enrollment 2025. And I said these things are interwoven and not just thematically, but structurally, because what we're hoping is that this year, 2024, we're going to have constructed a set of messages and be delivering them in an organized way that we'll be able to test the results of the messages and know which one. Start with anecdote, and I think this is a good message. Well, Louis, I think that's a good message. We'll start with the anecdote and intuition that we all start with, but then from that, we will be able, we hope, if we work this out right, that we'll be able to measure which of those messages were the most effective, what's the best delivery channel, and then use those lessons in the 2025 open enrollment sessions. So we're kind of viewing this not as a one and done. We're viewing this as a process. And that's important because, anecdote is great, but I'm here to tell you science trumps anecdote. And I promise you, having spent years working inside the insurance industry, I promise you, these multi-billion-dollar corporations don't make their strategic plans based on anecdote and intuition. That maybe gets them in the room, but that doesn't, they use science. They do robust testing of their messages. And so we're hoping to try to use some science on our side as well. So that's about as far as our strategy goes, except that sprinkled in there, of course, will be the 2025, new filings for the Medicare for All bills. And we, even though, it's naive to think that those bills will become law during the next cycle, it's really critical to keep them alive and to keep them getting better and keep organizing around that. So that's the stuff that's sort of afoot. A couple of more things just to mention is in this campaign, we are, to be clear, we're not, as much as I'd love to see, traditional Medicare be like ramped up to perfect and Medicare Advantage not have a niche anymore. We know there's a lot of people that are in Medicare Advantage today because they're afraid of being in traditional Medicare without Medigap. As you know, traditional Medicare has a pretty significant cost sharing, they call it, where the copays and the deductibles are without limit and can bankrupt you if you're in traditional Medicare. And for that reason, 90% of people in traditional Medicare protect themselves one way or another by having a Medigap policy that largely eliminates the copays and deductibles. Few people don't feel they need that, but most people do. And most people feel like if they can't afford the $200 for a Medigap, that they just don't have a financial option of anything but Medicare Advantage. So that's an unlevel playing field. That's just not fair. They also, most of the people that are opting into Medicare Advantage are also thinking, well, I'd like to have a hearing benefit. I'd like to have a vision benefit. I'd like a dentistry benefit. I'd like a pharmacy benefit. And there's these other parts that are built into Medicare Advantage because of the subsidies that they get. So there's these other benefits that you can get in Medicare Advantage that you have to pay extra for in traditional Medicare. That's also not fair. So we think that should be leveled. We think that you shouldn't have to give up traditional Medicare to get hearing, vision, dental, pharmacy, and all that happy stuff. So we are in the process of crafting a bill that would do just that. That would not call for the end of Medicare Advantage today because people are trapped there. They need a landing pad. They need a place to go. So we're not calling for that, much as I would like us to be able to. We're not about to do that. But the bill we're crafting would do the things I just talked about. It would introduce some maximum out-of-pocket expense in traditional Medicare. And we're hoping to have that be as low as $1,000, which would make a huge difference. The maximum out of pocket in Medicare Advantage today is statutorily set at around $13,000 in and out of network. Realistically, most Medicare Advantage firms offer a $5,000 maximum out of pocket cost. We still think $5,000 is too high. So we're crafting a bill that would hopefully have a $1,000 maximum out of pocket expense, thinking that people for whom that's a prohibitive amount for getting health care, many of them are also already dual eligibles in states that expanded Medicaid, so they would not be quite as struck by that. So we're hoping to craft a bill that would introduce a $1,000 maximum out-of-pocket cost that would embed hearing, vision, dentistry, pharmacy, and other benefits into traditional Medicare, so that if you go into traditional Medicare and don't go into Medicare Advantage, you don't have to deal with, now I've got to shop for a pharmacy benefit. Now I've got to shop for a Medigap. Now I've got to do this. No, it should be as simple to get into traditional Medicare as it is to go into Medicare Advantage. So we're working on a bill that would do that and funding it largely through eliminating those subsidies that Medicare Advantage firms get. So that's in process. We're talking with a few different members of staff of Congress people and a few members of Congress. And it'd be speaking out of school for me to tell you who they are and where you are in that process. And there's nothing today for you to do. The process is afoot, but there's no action for you to take today. But tomorrow, a month, maybe 6 weeks, I don't know when it'll be, but soon, this summer for sure, we're hoping the heck, there will be this bill that would level the playing field between Medicare Advantage and traditional Medicare. And when we get that bill filed, EGAD, that should be an organizing moment for us all to try to have discussions about it and try to get it to happen. So there's that. So The action requests for the next few months: number one, sign up yourself or recruit people to go to the Be a Hero training on June 26th. Number two, to help us get more people to sign up for the PNHP training that'll be coming up shortly after that. And then probably most importantly, figure out what you want to do. It sounds like you already decided you would like to do it. Figure out what you would want to do around the September 30th day of action. And let me just pause here and copy my links, and I'll put it in the chat. And then I can pay attention again. Give me 1 second. Where's the chat? There it is. I did do my homework. I made the links ready. There you go. Okay. Okay. That's a lot of stuff.
Ready for some questions?
You betcha.
Okay, first I'm gonna look around the room. Anybody? Rick, go ahead. We'll take a couple from the room and then a couple from Zoom and go back and forth. Rick.
Okay, thanks for that excellent presentation, Dr. Weisbart.
Louder.
Oh,
I can
that's
hear.
not- Oh, okay. Well, maybe some people can't. So I'll shout. Yeah, I'm sure you're aware that Steffi Woolhandler and David Himmler published an article about a year ago, a little over a year ago, talking about the acquisition of medical facilities by these private, well, various things, corporations, hedge funds, whatever. And basically came to the conclusion that if we don't acquire the facilities also, I guess their argument was, they'll charge whatever they want. And you've had a victory here where you did limit this one particular rate increase, but it's a big jump from there to think that we can control all the other costs, because they're also buying practices, as you mentioned. They already own the biggest pharmacy benefit managers. Corporations. They've got a separate subsidiary that does nothing but billing, which should be the main job of an insurance company. So obviously their bet, and as you said, they study this stuff pretty carefully, is that they're going to be able to keep us from controlling all that. So, I mean, there is another option, and people don't want to see me talk about it because it sounds like socialism, and that is a NIH sort of system, or a VA for all, if you will. I mean, it doesn't have to be exactly the VA, and that has its own political problems because the VA is being privatized. That is a major problem there. So the reason I'm doing this is just so the audience understands what you probably already understand. I'm not trying to explain it to you, but I'm sure that PNHP leadership has discussed that, being these are two co-founders, or founding members, I should say. So what does the leadership say about that?
Yeah, I mean, Dave and Steffi are, frankly, two of my all-time life heroes. I've learned so much from them, so it was a great article that they wrote, and I don't know that I disagree with their analysis at all. Honestly, strategically and politically, that's a big lift, but I don't know, but that's not actually where we would need to go. I don't know. I think that's a really good example of what I said at the beginning about this is a target-rich environment, and we sort of made a decision that we could either take a little bit of our few resources and try to touch on every one of these topics, or we could do a deep dive into one that was the poster child. And we made the board discussed that question a couple of times, and we made the decision that we would be more likely to be effective both at community education and public education and at influencing members of Congress to actually move things and have bills advanced if we focused on one piece. So rightly or wrongly, I think rightly, we picked focusing on Medicare Advantage, but that shouldn't be in any way meant to say that there's anything wrong with the analysis and recommendations of Dave and Steffi. It's just not where we're focusing right now for a variety of strategic reasons.
Sure, but I guess what I'm
We
getting at
better
is,
let Leo ask his
can
question.
I just, one
Quickly.
really quick. What I was getting at is, has PNHP rejected the idea? I mean, are they dead set locked into Medicare for all versus looking at the possibility of a system where the government also owns facilities? And,
Yeah, you're asking to, National Health Service versus National Health Insurance. And yeah, we've been pretty focused on National Health Insurance and I don't know that anybody disagrees with National Health Service as a solution. It's just not where it's not where we're focused. It's not, we made a decision not to, make that a campaign for a variety of reasons.
thank you.
I got a question.
Leo had his.
Yeah, and then we'll go to,
From your earlier remarks, I gathered that one of the main reasons you're opposed to Medicare Advantage is you see that as an obstacle to expanding Medicare as we have to Medicare for all. If you disagree, please tell me. I'd like to ask about the subsidies, though. For years, I have assumed that Medicare Advantage is paid through our contributions, our deductions through our working lives. And then once we retire, then our Medicare B payment, I just assume that that's what Medicare Advantage, but you're talking about subsidies of 80 billion. I know I'm not paying 80 billion. So where does the 80 billion, and I'm not questioning what you say, but where does the 80 billion come from?
Yeah, thank you. It's a good question. So, traditional Medicare is kind of straightforward, right? I mean, Medicare writ large, you pay your taxes and then you turn 65 or you develop one of the other conditions that gets you into Medicare and you get your red, white, and blue Medicare card, right? And then you go to see the doctor, you go to the hospital and the doctor or hospital essentially bills Medicare and Medicare pays the doctor or hospital. And kind of that's all there is to it. There's a fee schedule, it's $1.95 for this, or it's, $100 for that. And it's almost that straightforward, although not really, almost that straightforward. Medicare Advantage is a completely different animal. And as a result, there's all sorts of games that have been set up so that they get paid more for the same care. So when Medicare Advantage was created, the insurance industry came to government and said, really, government delivering, paying for healthcare? We're the industry, we're a business, we can do this better. So they said, pay us 5% less than you would pay for the same people in traditional Medicare, and we will save you money. So it was built on that premise. How do you do that? So what they did was they took everybody that was in Medicare, figured out what the average person costs in Medicare for a year, and then they prepaid the insurance companies that amount less 5%. Well, the insurance companies figured out pretty quickly that wasn't, these people are sick. You can't do that. So they went back to Congress and got that rate jacked up so that they're paid more than the average person. I'm giving you the longer answer than I probably should. The bottom line is they're not paid fee for service for the care. They're paid on a capitated flat amount per year. How much should that be? Well, they have games to make it look like you're sicker than you really are, and therefore the capitation rate is higher than it needs to be. They fiddle with the benchmarks, they fiddle with the whole thing. And read our report, it unpacks there's a handful of different mechanisms, but the bottom line is the annual amount that they are paid per person is 22 to 30% more than that same person would have cost if they were just paid fee for service through traditional Medicare. That's where the $80 billion is. I gave a long answer to a simple question. You can tell I'm tired. They're paid more, they're paid per person, and they're paid more per person than that person would have cost were that person in traditional Medicare. And some of that money goes to producing an out-of-pocket maximum. Some goes to hearing, vision, and dental, and stuff like that. But that's not the lion's share. The lion's share goes to supporting their overhead and their profits and all sorts of other hidden gimmicks they have. So it's complicated, but also real simple. They're just paid more.
we'll take one more question in the room and then we'll go to questions online. Alex.
Yeah, thank you, Dr. Weisbart. My question, since you're aiming for the MA, you're aiming at MA and you're aiming at public education, I was just thinking of a couple things. First, like a truth in advertising campaign kind of thing. I think there was some federal legislation afoot for eliminating some of the deceptive advertising that, you know, draws people into MA. So I'm wondering about that. And then the other part about that also was AARP, you know, they really pushes MA. They're involved in that. I'm wondering if you guys are nationally, have anybody, you know, advocating within, you know, top level AARP, because they always seem to be pushing MA instead of Medicare.
Thank you, that's great.
Yeah, there are some real changes. You know, the CMS has changed the rules about advertising, and there's a number of ways in which, you know, CMS is trying very hard to address some of the things that we're talking about. Problem is, CMS doesn't have anywhere near the resources to police these shysters, and they never will. You know, and it's really hard to take a really badly, perversely incented system and just put a few more guardrails around it to keep people from flying off the road. That's, you know, the problem is it's fundamentally flawed. It's fundamentally flawed. So yes, there are some things that are being done that are better by CMS. You know, we'll wait and see how well that goes within AARP. I thought, well, golly, you know, they're for old folks, right? You know, they should be our best ally. Let's connect up with them. And they haven't been all that interested in this campaign, because and I can't say why, but you know, it seems to fit with the fact that their profit, you know, they make a lot of money from their Medicare Advantage, the relationship with United for Medicare Advantage. So I've got it, you know, they're not going to be, eat with the one, you know, they're not going to be our allies in this fight, although maybe they will, you know, keep on trying, but I haven't seen that as fertile ground.
Okay, thank you. We need to get a couple questions from online, and we'll come back to people in the room. Fritz, do you see any questions there?
Yeah, we've had some questions come in via the chat, and then after that, some hands went up. So the first question that came in via chat was from Dr. Bruce Thompson. Dr. Thompson, go ahead and take yourself off mute.
Oh, I was hoping you would read it, Fritz. Okay, so Ed, thank you for this presentation. It's a great presentation, and I look forward to reading those 2 reports. I haven't read them yet, but what I have read is quickly went through the state of Maine's insurance laws about Medicare Advantage. And we know that there are 4 states in the nation that allow people enrolled in Medicare Advantage to switch to traditional Medicare. What I couldn't figure out in Maine's insurance laws, it looks like there's a 90-day window where people can disenroll from Medicare Advantage and go ahead and enroll in traditional Medicare. And that 90 days comes with the annual open enrollment period. But what I don't know, and it wasn't clear to me in my reading, was that if a person has been on Medicare Advantage for 10 years and they come to making the decision that they want to disenroll from Medicare Advantage during the next open enrollment period, are they still able to do that, or is that 90-day window only on your first enrollment with Medicare Advantage?
Yeah, it's an interesting question. So, and I can't say I'm completely intimate with Maine, but I do know the issue. And so let me maybe unpack that a little bit more. Anybody can, during open enrollment, leave Medicare Advantage and go back to traditional Medicare. Anybody in the country, everybody has that option. The problem is that, as I was alluding to, traditional Medicare has what is it, $1,600-$1,700 co-insurance for every hospitalization, and 20% co-payments for every office visit, every outpatient care. And so, if you're sick and you wind up being hospitalized 2 or 3 times, or you wind up needing to go get healthcare every week or every month or whatever, that can add up to a bankruptcy level. So most people in traditional Medicare need to have, or believe they need to have, Medigap, which eliminates those copays and deductibles. So the reason that the thing you're bringing up is that, sure, you can go from Medicare Advantage to traditional Medicare, but there's no guarantee that you can purchase Medigap. So, most people think that the Affordable Care Act created guaranteed issue. That the Affordable Care Act eliminated the concern about pre-existing conditions. We hooray, no pre-existing conditions. They have to write me a policy. If I go to the ACA exchange and I want a policy, they can't ask me if I've got blood pressure problems. They've got to give me a policy. It's called guaranteed issue. It eliminated the pre-existing conditions. Hooray. Most people think that's for all of insurance in the country. And no, it wasn't. It was only for commercial corporate insurance on the ACA exchanges. So once you turn 65 and you go into Medicare, those protections where you have guaranteed issue of insurance disappear. They disappear. The first 6 months that you're in Medicare Part B, or the first 12 months that you're in Medicare Advantage, you still have federal guarantee of being able to purchase Medigap without being given a health survey questionnaire, without being underwritten, without being asked if you've got diabetes. The first 6 months that you're in Medicare Part B, or 12 months if you're in Medicare Advantage, you're guaranteed that if you decide you want to buy a Medigap policy, the insurance company has to sell you Medigap, and they have to sell it to you at the same rate they charge everybody else in your community. That's a nice protection. That protection disappears after 6 months in Part B or 12 months in Medicare Advantage, except in 4 states. And I think Maine was one of the 4. I'm pretty sure it is one. And I
Maine,
forget.
Massachusetts, Connecticut are 3 of the 4.
Yeah, I think that's right. And in those 4 states, the state has made it mandatory for any Medigap policy you're guaranteed that you can buy a Medigap policy at community rates without a health survey questionnaire or underwriting anytime the rest of Massachusetts, anytime for the rest of your life. So when I first got wind of that, I live in Missouri, right? And we're not one of the 4 states. And I thought, well, we could rally around that. Why don't I do it? Actually, Kate Tillow brought this up for Kentucky, and that's what got me interested in this. And I thought, oh, that's interesting. So I looked into it more. I thought, let's do this in Missouri. Maybe you'd want to do it in Oregon. I would discourage you from adopting that as a campaign that consumes resources, because of 2 things I learned when I was looking into it. The first is those 4 states, they don't have a real difference in Medicare Advantage penetration. They don't. I compared those 4 states. I'm not a statistician. I don't have Dave and Steffi skills. I picked a few random zip codes within those 4 states, and I found states that I thought were kind of comparable, and I picked a few random zip codes in them, and I looked at what the Medicare Advantage penetration rates amongst all of them were, and I didn't see any pattern that the states that had guaranteed issue had lower Medicare Advantage penetration. So it's hard for me to see that that's a strategy that will get us to move to getting people away from Medicare Advantage. And then I also looked at premiums for Medigap, and it seems that the premiums for states that have these protections, Medigap is more expensive, as you would expect, right? Because sicker people are the ones that would want to go there. If they have guaranteed issue, they're going to go into Medigap if they're sicker. So of course they're going to have this, it's called adverse selection. So yeah, the states that have these protections and don't do much else have attracted sicker people into their Medigap policies. And so the premiums are higher for everybody who's in Medigap. So, those 2 things made me think, it's not going to actually hurt Medicare Advantage, and it's going to hurt the people that are in traditional Medicare. This doesn't seem like, I wouldn't. So I decided not to adopt it, not to do any kind of campaign in Missouri. And I would discourage, you do the arithmetic yourself, but I would discourage that as a campaign. That's a long answer to a short question, but
Yeah,
Well, I
we
certainly
better,
appreciate your perspective, and thank you so much for that additional information.
we better keep rolling here. We'll take another question from online, and then I think there's another question in the room. But
Sure, there's, excuse me, actually, a quick one. I'll ask this one for Phyllis. She's asking if we can post some links to reports on both costs and outcomes for Medicare Advantage. And so I think we can probably pull some of that kind of stuff together and get that out to the group and move forward. The next hand that is up online is Michael Pan. Michael, could you go ahead and unmute yourself and ask a question?
It's John,
thank you.
John Rickard was up first.
oh,
No, Michael had posted his into the chat first. Sorry.
Oh, okay. Yeah, so I had a question, Dr. Weisbart. It's a very good presentation when you talked about the Medicare Advantage. I was contracting it, I was privatizing Medicare fully over time. Yeah, and the question I have is this, right? Because I said in the chat, although local chapters with AMA have met with Congress to increase, Medicare's reimbursement rates for their profession, they are still opposed to Medicare for all, meaning they want to preserve the Medicare Advantage plans in addition to the traditional Medicare. And the question I want to ask is, how do you frame the issue and flip the script for them to go on board with, Medicare for all, but at the same time, gradually restoring the traditional Medicare?
yeah, we give this a lot of thought. And that's what's really so exciting about this campaign, frankly, is what we're talking about with leveling the playing field and with improving traditional Medicare and the subsidies. These messages actually seem like they're resonating in a more of a bipartisan way. We've been able to get meetings with both parties, both major parties, to talk about this stuff. Because what are we saying? We're saying that the Medicare Advantage companies are not doing what they were tasked by Congress to do. Here's evidence that they're not lowering cost. And now we're not the only ones out there saying that. MedPAC is saying that, all kinds of groups. So hey, Congress, be fiduciary, conservative Congress people. You're allowing these corporations to raid the funds. That's, so that's a message. So we had people tell us, we had Republicans tell us that they agree with that. They don't agree with us about, then we say, well, let's take those rated funds, let's redirect those back to improving traditional Medicare. Well, they don't always agree with that. but the part about so it's building a changing the sense of these are the corporations that are going to be helping all of us. So there's some people for whom the only part of the message that gets through is the let's stop wasting the money. Let's stop subsidizing them. They're supposed to be lowering costs by improving health outcomes. Let's make them do that. So that message works for some folks. Other folks, the fairness message works of, hey, we shouldn't have to give up the freedom of choice of doctor and freedom of choice of hospital to get hearing benefits. That's just not fair. If those corporations are doing such a darn good job, let them compete on a level playing field and make their case. They say they coordinate care and that makes healthcare better. Okay, well, let them do that and prove that. And we know they can't, right? Because that's Boulder Dash. They can't do that. So they're competing by getting overpaid, being able to throw in free ice cream, and make it look like that they're doing a better job. And all we're saying really to this group in the middle is let them compete in the way that they were charged by Congress to compete. Let them improve care and lower costs because they've gotten better health outcomes. Don't overpay them so that they can throw in more ads on the TV machines. No, let's be fair, have a level playing field and let them compete in a free market kind of way. That message resonates too. The more, the further step of.
Hey,
I'm Julia.
okay.
I get to be your nurse for the night.
Let's see.
That is
I could use
awesome.
it.
Yeah.
I don't think I need a nurse tonight, but thank you.
Beautiful, but also.
You must.
I'll find it.
This for now, and then we can always open it back up.
Anyways, yeah, so then the next one follow-up is quickly. So restore funding cuts for Medicare. Like, how do you convince, medical specialists and surgeons that improved and expanded medical will be better based on your research analysis? They might not be might not be convinced because the medical specialist surgeons, they how do I say this? It appears to me they think that PNHP cherry picks data, and so this leads me to this follow question. Do you think it's necessary to have like group meetings or individual meetings among surgeons and specialists? And if you do, what strategy would you take? Because I know a lot of them have a financial interest. Even if we gradually removed Medicare Advantage plans, we know because they're being overpaid by MA plans.
So, oftentimes Medicare Advantage companies do promise and contract for higher rates per thing than the traditional Medicare rate is. But what we've been hearing more and more from physicians and medical groups and hospitals around the country is that the denial rates and the disapproval and the denial rates later and such wind up with so much unreimbursed care that at the end of the day, although the rate per reimbursed case might be a little bit higher, the actual rate per case is lower than traditional Medicare in many cases. So, and it's way more complicated. I mean, nobody likes having to deal, a lot of docs don't recognize the difference between Medicare Advantage and Medicare. A lot of physicians don't yet. And so they just, Medicare, all those prior authorizations, it's terrible. That's Medicare Advantage. You hate the nightmare of dealing with those prior authorizations. That's not traditional Medicare. That's not what we want to do. So there's that set of arguments. Another set of arguments when physicians are concerned about I can't live on Medicare reimbursement rates. First of all, if you look at the cost of healthcare around the country and how much physicians earn around the country, every analysis about the economics of Medicare for all is based on the premise that physicians would make the same or more money. There are very progressive groups that have done these analyses, and there's very conservative groups, including the Koch brothers. The Koch brothers, through the Mercatus Foundation, funded a study, about 3 years ago or so, that looked at, how can we afford Medicare for all? And their answer, the Koch brothers' answer was, yes, we can. So, there's that. And built into the yes, we can afford it was paying physicians, total amount spent on physician services was the same or higher. So nobody is saying that we need to cut physicians' reimbursement writ large. Do we want to maintain the same sort of disbalance between primary and specialty care and all of that? Well, we probably want a more equitable and fair way to set up how we set that up. But nobody's talking about neurosurgeons having to take a dramatic cut in there. Nobody's talking about that. It's not on the table. So if you have a few who are just like desperate, no, that's just not where you're gonna get much traction. But there's a lot of good arguments we can make that do actually resonate.
Let's take one more question online and then one more in the room. We do have some other business we need to get to, and I know it's getting pretty late at your end of the country. So, but Fritz, have you got another one that you'd like to?
Yeah,
put out?
John Rickert, you have your hand up. Go ahead and unmute and ask your question.
Yeah, I do. I almost forgot my question here, but it's coming back to me. I used to work for a SHIBA here in Oregon, Senior Health Insurance Benefit Assistance. And after talking to just tons and tons of people, it was very understandable for me why people went with Medicare Advantage, especially the ones that weren't very sick. And they either got a zero copay, a zero cost for their supplemental, or $29, $30 a month, which was very minimal, especially when you compare it to what traditional Medicare, when you needed a plan there, which was Med Advantage, or was the, what was it? What's the plan that Medigaps. And for my age right now, for a Medigap policy, I'm going to pay $380 a month. and I'm very healthy. So it's very understandable why I'm into a Medicare Advantage, even though I don't like what's going on. Okay. So here's my question. Given that I have a choice of Medicare Advantage or traditional Medicare, why can't I say I want traditional Medicare and you, CMS or the government, take the money you would give to a Medicare Advantage carrier and pay my $380?
Wow.
You would save money doing that. You definitely would save money because, as I understand it, the government's paying these Medicare Advantage people around $800 per person per month. Is that wrong?
I don't know the number, but yes, in essence, I mean, the logic is there. And the good news is we are trying to craft a bill that will get into Congress in the next month or two that would do exactly what you say, and not just for you, but for everybody in the friggin' country.
Mm-hmm.
That's
Yeah.
exactly what we want to do. We take the money that you're overpaying, that you're subsidizing these corporations, and put it into Medicare. Let everybody get that stuff. Stop. So I'm spot on. And if we get this bill filed like we're hoping we will, that'll be a great way to, that'll be a great way to focus your, your perspective. It's great.
Yeah. It only makes sense to me. I just can't believe they wouldn't do that. I mean, okay.
Well,
Thank you. Thank you very
my-
much. I appreciate, I've listened to both your talks. Thank you very much.
Do we have one last question in the room? Tim?
Yeah, my question would be, realistically, is there any way for traditional Medicare and Medicare Advantage to coexist? To me, it doesn't seem like there is. Because one or the other is gonna put the other one out of business.
Well, you're correct. And I mean, today they're not coexisting. One is, one is the parasite that's, draining the blood out of the other. And I'm willing to see the experiment, level the playing field, have traditional Medicare with, almost every doctor in the country, any hospital, no prior authorizations, no this, no that. If that's at the same, level the playing field so that they have the same benefits, but traditional Medicare has the advantages that we know that it has, and Medicare Advantage claims that it can make value by improving care. They claim that. So if they could let them compete like that, I think that'll completely reverse the dynamics of the competition. And that, I think I agree with you. I don't think they're gonna. It's a pretty easy choice. It's a pretty easy choice.